Dr. Mallika to speak to us on Fibrin glue in the management of complex retinal detachments.
Good afternoon. So I'll be speaking about my experience with Fibrin glue to close retinal breaks successfully in complex retinal detachments with silicone oil in situ for tamponade. So glue-assisted retinopexy for simple rhegmatogenous retinal detachments without tamponade has been described earlier by Dr. Mudit Tyagi and his team. But this was done primarily to obviate the need for any tamponade. It has not been reported for complex retinal detachments with silicone oil tamponade. So we had a patient almost 2 years back, complex diabetic detachment. It failed after the surgery. There was an open break superior to macula. So we went in and after a little bit of membrane peeling, closed the hole with Fibrin glue. The oil was already in the eye from the primary surgery. And 1 week later, the retina was reattached without any need for prone positioning also. So, the patient was seen after 8 months, and there was no inflammation, there was no oil emulsification, IOP was normal, and the glue was not seen. So encouraged by this, we took up a few more patients of complex diabetic RD. And as we do a dissection, there is some bleeding, some iatrogenic break, and then these breaks get covered by blood, which does not get dislodged. So difficult to laser these breaks. So after fluid air exchange and drying the surface, I instilled the two components of the Fibrin glue sequentially over each break. And oil was injected. You can see the glue in the first post-op week, but it's not there by the 3rd week, and retina is nicely attached. So similarly, another patient, because of bleeding, laser was not adequate. So 2 breaks are being sealed with 2 drops of, with the 2 components of the glue after fluid air exchange and drying the retinal surface with good attachment post-operatively. This is a situation where the break is very close to the foveal center, so we don't want to do laser in that area. So after releasing the traction, the 2 components. Now here we injected the less viscous component first, so there is a large collection pool. However, it has plugged the hole very well and the retina is attached. So then we extended it to non-diabetic detachments. Generally, when we have a macular hole RD, we are able to close it by doing an ILM peeling, but sometimes ILM peeling is not successful or it's a failed macular hole RD, like this one was a failed RD. So you can see that we instilled the glue over the macular hole and it's attached. Similarly, a young boy with a chronic, very old RD, and macular hole was the only obvious break. So after doing an ILM peeling, we put some glue for additional security. And by the 6th day, we can see the glue, but by the 10th day, it's almost gone, plugging the macular hole, and you see the good result with no adverse effects. Now, in this patient, ILM peeling could not happen. So you see the hole is still open, but the RD has closed, RD has settled with the macular plug of Fibrin glue. So the only things that we realized during the technique is that the 2 components should be drawn separately in 2 different 2 ml syringes rather than 1 ml, because 1 ml is longer, more difficult to maneuver. And it's better to inject the more viscous blue top sealer protein first, so that the amount of injected material is less and you don't have a large pool. So you can remember it as blue top first, blue first. And the other is that these needles get blocked before you can inject. So first squirt out some material before going into the eye, because if you try to overcome the block close to retina, it comes out with a great force which can enlarge the retinal tear and lead to excess pooling as well. And in general, avoid excess injection. That is the commonest problem. Just 1 or 2 drops is enough. But this is difficult because it's each component is transparent, and even when they mix together, they remain transparent for a few seconds. So the surgeon is not sure how much has been injected. So the tendency to over-inject has to be curtailed. Now, this was a patient which by chance I realized that the glue post-operatively has gone subretinal, you see the track, and then it has been within few days we see there is atrophy in that area. So this means that we should be very careful using it for macular hole closure where we don't want perifoveal atrophy. And similarly, excessive injection even in a peripheral break can cause it to go subretinal, causing the break to remain open, which can cause a persistent RD actually. So in this patient, we had to reoperate and it reattached after additional membrane peeling. So in summary, fibrin glue can be a useful adjunct in the management of complex retinal detachments, especially when laser for retinal breaks is not possible due to bleed, edema, or proximity of break to the macular center. The glue resolves very quickly and is not seen even as early as 1 week after the surgery. There are no adverse effects with silicone oil in situ. There is a rapid retinal reattachment compared to when it is not used, and the need for post-op positioning is reduced because the hole is already plugged and does not depend on the laser effect to come in 2 weeks' time. But we should avoid routine use for macular holes as it can in some cases cause retinal atrophy when it migrates subretinally, and it can move subretinally and keep a break open. Thank you.
Excellent presentation, ma'am. Just wanted to ask a question that do you have any experience of using the glue over a retinal autograft in a failed macular hole?
I haven't used it for macular hole at all. I've used it only for retinal detachments till now. I've never used it.
We have tried placing it over a retinal autograft and we were using it for failed macular holes. All 3 times, somehow the glue was not to be found anywhere post-operatively. That's why I was asking that question.
That's an advantage if it dissolves quickly, but at least first post-op day, I think it should have been seen. Maybe the patient.
So, Dr. Mallika, very nice presentation, but I just wanted to ask you that what about the permanent retinopexy? Because here, as you mentioned, that you're not doing laser, and you're showing the advantage that when there's blood or edema, when you're not able to do laser, but after the fibrin glue disappears, then what happens? Because breaks open up.
Yeah, so what happens is most of these patients, it's not that we didn't even try the laser. We have already attempted laser, but it was not adequate. So I think if the retina is attached because of the glue which plugs the hole, possibly that laser pexy comes in. And I have not had to touch them up post-operatively, and none of them have reopened.
But you didn't do the laser?
No, we tried. We did try, and this was given after we tried and we were not satisfied with what we got. We tried.
The question of using it as a graft. So the problem is that we have not used it for retinal autograft, but we tried it for autografts, allografts. The problem that happens is that when you put fibrin glues a liquid, it sometimes tends to displace your graft. That is the first problem. The second is for the question that you did not see the glue immediately the next day. Is it that you put both of the components, the thick one and the thin one together, or was it a fresh glue?
No, the technique that you had shown in DRM, first the thick one, then the thin one.
So then ideally the next day you should see a coagulant. Did you also use air by any chance?
Yes.
So probably the next day, by the time you assess the retina, it was the 6th day or the 6th day and you did not find it? Or the
Further discussion you both can have over coffee. Thank you so much.